Hi everyone, my name is Saeed Hashem. I'm an outpatient geriatric psychiatrist at McLean Hospital in Belmont, Massachusetts. I'm also a clinical researcher in the geriatric psychiatry research program at McLean, and I'm an instructor of psychiatry at Harvard Medical School. So today I'm going to resume our overview on major neurocognitive disorders in older adults. So this is part 2, geared towards more advanced practitioners and young learners in the field of geriatric psychiatry. If you haven't watched part 1 of this series, I strongly encourage you to do so. So I have to acknowledge that this presentation is supported by a HRSA grant from the US government, the Department of Health and Human Services. However, the contents of these slides and my presentation do not represent the HRSA or the Department of Health or the US government. I do have to declare some conflicts of interest as I work as a co-investigator on active clinical pharmaceutical trials with Biogen and Eisai investigating the use of monoclonal antibodies in mild cognitive impairment and early Alzheimer's disease. This presentation also includes some off-label therapeutics for Alzheimer's disease and related dementias that were discussed in published medical literature. So to keep things within the same age-friendly framework that we use in our services, among the 4 M's, we will focus on this presentation on mentation and what matters. So let's quickly go over what are the types of major neurocognitive disorders that we know of among older adults. So here's a list of 16 different types of major neurocognitive disorders that can affect older adults, and it's a descending order of known frequency. And as you see at the top is Alzheimer's disease, which is the most common form. In this presentation, we will focus more on the other types of major neurocognitive disorders that can affect older adults. So I realize it's a lengthy list, 16 is a lot. So in the coming slides, I will try to focus on the cardinal signs and the high yield facts of each type of them. So we already discussed Alzheimer's disease in the first part. Again, if you haven't watched that part, I strongly encourage you to see it. Let's talk about the other common major neurocognitive disorders in older adults. So the second most common form of major neurocognitive disorder in this age group is vascular disease or vascular dementia, which is caused directly due to cerebrovascular disease. The clinical presentation usually varies. It may present with non-amnestic MCI, which was further explained in the first part of this series. It can present with a focal neurological deficit with some cognitive impairment. Cued recall is usually better than free recall in these subjects. Gait instability, mood changes, and urinary incontinence is also common. And they may present in different courses. So with small vessel disease, the course may be chronic gradual decline, whereas in infarcts and hemorrhages, it may present in a stepwise decline. It is the second most common after Alzheimer's disease, accounting to 20 to 25% of cases. Slightly higher prevalence in Japan because they have a higher overall prevalence of cerebrovascular disease. And the peak is usually between the 4th and the 7th decade of life. And 80% of them will have a history of hypertension. So the etiology of vascular dementia depends on the type of infarcts or hemorrhages that are affecting the brain. With lacunar infarcts, the presentation may look like a subcortical dementia. Recurrent strokes may cause multi-infarct dementia with a stepwise decline, whereas small vessel disease usually leads to the chronic gradual decline in cognition and mood, and it presents as white matter hyperintensities around the ventricles on brain imaging. Cerebral amyloid angiopathy may show as a unique form of vascular dementia, with sometimes it presents with episodic nature of symptoms. The most important risk factors are advanced age and hypertension. Other risk factors include dyslipidemia, smoking, obesity and sedentary lifestyle, diabetes, and a history of prior stroke. These risk factors were according to a large cohort study called the Interstroke, investigating the risk factors, the modifiable risk factors of cerebrovascular disease. Once you cross the age 80 years of age, atrial fibrillation jumps up on the list to be second after advanced age. So the pathology is simple. Brain damage follows the blood supply distribution. White matter is usually more affected than the gray matter. And then you see tissue loss, atrophy, and encephalomalacia after that. The diagnosis is based on history and examination, neuropsych testing, and you may benefit from getting a SPECT scan to differentiate vascular dementia from Alzheimer's disease. So the prognosis depends on the management. Optimal control of the cerebrovascular risk factors that were mentioned in the prior slide, you may reach a plateau or even slight improvement in cognition and mood. If the etiology is untreated, it becomes comparable or worse than Alzheimer's disease. The cause of death is usually the complication of cardiovascular and the cerebrovascular disease itself, such as pneumonia, aspiration, urinary tract infections, or complications of recumbency. Treatment is usually directed at the underlying cause of the cerebrovascular disease. Otherwise, it is managed with the same 3 pillars of Alzheimer's disease management that was mentioned in part 1, except for the use of monoclonal antibodies.